is all about. And we had looked at many of these disorders in terms of categorization, looking at signs, symptoms, evaluations, and things like that. Having completed that, now let's start taking these disease processes one by one so that we become master in that. So first disorders are the airway disorders, and there are three of these: asthma, bronchiectasis, COPD. We're going to tackle asthma today. You and I have already talked about it, that this is an airflow problem, airflow resistance problem. Patients cannot breathe out. I cannot emphasize this anymore. Patients cannot breathe out, so they have expiratory wheezing. The chest x-rays may be normal. And there are three of these: asthma, COPD, and bronchiectasis. COPD, which is chronic obstructive pulmonary disease, is actually two pathologic processes going on at the same time. That's why we call that as chronic bronchitis and emphysema, and we'll learn about that tomorrow. Asthma, COPD, and bronchiectasis may overlap onto each other as you see it here. They may at sometimes overlap, and sometimes distinction between one to the other may not be possible. But the roadmap that I've given you before in terms of looking at history, physical examination, sign and symptoms, and follow-up, and ABG, and things like that do allow us to give some differentiation from the other. In a real clinical setting, you can differentiate clearly between asthma and COPD up to 95% of the times. 5% of times there may be an overlap. So that's why the Venn diagram shows here that some patients with asthma may have some features of COPD as well. For example, I may have asthma, but I've been a smoker. In that case, I may have developed some COPD from smoking and a history of asthma. So it's an asthma COPD overlap. That kind of overlap pictures do exist. But we want to focus just on pure asthma as of today. So what is asthma? It's an airway disorder. That's old news. It's an airway disorder which is inflammatory in origin. A cell of inflammation in asthma is eosinophil. I drilled that down 50 times already. It's an airway disorder which is inflammatory in origin, and the cell of inflammation is eosinophil, and in which results in increased airway resistance, means your airways become small, or your diameter of the airway becomes small. But if treated appropriately, the disease is completely reversible. So asthma is a chronic inflammatory disorder of airway characterized by reversible airflow obstruction. Reversible. COPD is not reversible. And bronchial hyperreactivity along with mucus production. What is bronchial hyperreactivity? Bronchial hyperreactivity means anytime the airway has a little insult, bronchospasm occurs much more severe as compared to healthy people. Remember, if you're drinking water and even one drop of water goes inside your lung, you start coughing violently. That's a normal response. But patients with bronchial asthma, even if there's mild inflammation, they have a very severe bronchospasm as compared to healthy people. That is bronchial hyperreactivity. So one more time, asthma is an airway problem. It is an inflammatory in origin. Most of this time, it is eosinophils are the culprit causing the inflammation. If treated appropriately, this asthma is completely reversible. And one component of asthma is mucus production. Whenever there's inflammation, there is more mucus buildup inside the airways. And also it has bronchial hyperreactivity. Okay. In between the bronchial asthma attacks, patients may have normal lung function. We learned that yesterday, that patients with bronchial asthma may have normal lung functions during asthmatic attacks, have obstructive lung disease, and when they recover, it is normal lung function again. This features comprise bronchial asthma along with bronchial hyperreactivity, which is extreme hyperresponsiveness of the airways to any inflammatory stimulus, leading to airflow limitation, basically wheezing, and also some mucus production. Having said that, if asthma goes on unreported, untreated over years, not months, years, it will become a fixed obstruction. So untreated asthma, the airway remodeling may occur and it may become a fixed obstructive process. That is well known. Okay. Asthma occurs in children as well as in adults. So there are two major peaks. One you see around 8, 10, 11, 12, 14, 15 years of age. Then there's another peak that we see in adults. When it occurs in children, it is more common in boys. When it occurs in adult age group, it is more common in women than men. If asthma is not treated and it continues to progress, it will result in hypoxemia. We learned it in my first lecture. And ultimately, if the CO2 starts to rise, these patients will have respiratory failure. And if it is not treated even properly at that time, it can result in mortality. So asthma has two peak incident times, one during 8, 10 to teenage years and second during 50 years of age. The one that occurs in children is more common in boys. One that occurs in adult age group is more common in women. So what causes asthma? Let's look at it and understand this a little bit more. We have learned it in parts piecemeal. Let's put this all together. I said there is an inflammation. Inflammation is reversible. It is eosinophilic. It is mucus production. And what causes this inflammation is an antigen-antibody reaction. It can be many kind of allergens. It can be inhaled allergens, it can be drug, it can be exercise, it can be anything. When it starts to occur, this nice clear airways becomes edematous and mucus production and obstructed. No wonder patient has difficulty in breathing. And if you do PFT at that time or spirometry at that time, you will see obstructive lung defect. In some ways, asthma is in a very simplistic way. I would like to explain asthma as a type 1 antigen-antibody reaction. Not clear to me how much immunology has been taught, but I want you to learn it my way. As we grow, as we are born, there is innate immunity. Innate immunity is what the infant acquires from their mother. Okay, and as we grow into this world, we develop more immunity that is called as adaptive immunity. So there are two immunity types of immunities for every human being. Innate immunity is what you're born with. That's generally not enough to pass entire life, but we have cells which develop immunity as we go along, and that's called as adaptive immunity. Adaptive immunity can have many types of antigen-antibody reactions. This one is a type 1 antigen-antibody reaction. Asthma is a type 1 antigen-antibody reaction. We will learn when I do sarcoidosis that that's a type 3 antigen-antibody reaction. It's totally different. So asthma is a type 1 antigen-antibody reaction. This is how it goes, and I want you to understand this. First time the child is exposed to an allergen, generally it's an inhaled allergen. Keep in mind, it can be an allergen that comes to you from the blood. Okay, so that's possible too. I have something I ingested, I took a medication that I ingested, and then it got absorbed, it got into my lungs. So that's possible too. First exposure of the allergens to the plasma cells, it produces IgE and immunoglobulin E against that antigen to neutralize it. Your plasma cells produce immunoglobulins E, which neutralize that antigen. Okay, that IgE binds to the basophils, and now it stays forever in your body. So you have a memory against that antigen. Anytime you're attacked again or you come in contact with that antigen again, these basophils and mast cells will become active. Easy. So people get immunized against any antigen, which is an allergen, means an inhaled antigen. It comes. Your plasma cells produce IgE against it. This IgE binds to the mast cells and basophils and stays there. Next time you're exposed to the same allergen again, you already have a memory against this allergen. As soon as this allergen goes inside your airways, it binds to the mast cells and the ES and the basophils, which have IgE already against it. It cross-links it. It leads to degranulation of mast cells and basophils. That's what causes resulting in various mediators, histamines, leukotrienes, things like that. This is very much akin to a localized anaphylactic reaction as well. So this is one simple way of thinking. Asthma is repeated exposure to the antigen because you're already sensitized to the antigen. Antigen binds, you inhale it, it binds to the already sensitized mast cells or basophils, which have IgE against the antigen. They bind it. As a result, the mast cells will break. They'll release histamines and leukotrienes and many other inflammatory markers, which will cause flushing, maybe some sweating, maybe some bronchospasm and things like that. That is one way of thinking asthma, but it is not as simple. It is not as simple. Here, as I show it to you, this is the antigen that you are inhaling. Once you're inhaled, these antigens bind to the basophils, etc. They degranulate and released. These antigens also bind to T cells. These antigens also bind to T cells. And there are specific types of T cells which are called as Th2 cells. Now, you are not going to get away from Th2 cells from going forward ever in your life, because Th2 cells attract eosinophils. Th2 cells attract eosinophils, and they attract these Th2 cells. Once this allergen attaches to or stimulates the Th2 cells basically invite eosinophils into the alveoli and into the lung. Once they come, one does that, they attract more eosinophils. They can, even from the alveolar capillary junction, these eosinophils move into the lung. And this eosinophils result in a cascade of inflammation, eosinophilic inflammation. If you were half awake yesterday, or maybe 1/10 awake yesterday, I made you say a statement: steroids kill eosinophils. I hope it is clear to you now why steroids are the mainstay of treatment for asthma. Because if you take steroids, they will kill this pathway right away, stop this pathway right away, and it stops the asthma. So now we learn that the inflammation is not just type 1 antigen antibody reaction. There is actually a big portion of interplay by Th2 cells as well. And what are these Th2 cells? Just to recap for this group, we have B cells. B cells produce immunoglobulins. We have T cells. T cells are two types, CD4 and CD8. Helper cells and killer cells. Helper cells basically produce markers which can help kill, but they don't kill the bacteria, the virus, anything foreign themselves. Killer cells kill it. I'm not talking about the CD8 count, which is the killer cells. I'm talking about the CD4 counts. Now, CD4 counts can be divided into many different kinds. One of them is Th2 types, Th2 cells. Th2 cells are types of CD4 cells, and they have specific predilection for eosinophil-derived inflammation. That's why I kept on saying in many iterations of my introduction to you that asthma is an eosinophilic disorder. Let's get more sophisticated today. Asthma is a Th2 cell disorder. Asthma is a Th2 cell disorder. And let's tackle this part of the pathway a little bit. Initially, antigen, degranulation of the mast cells and basophils, that lasts over 2-3 hours. But this eosinophilic pathway can continue for a long period of time. So that is what propagates the bronchial asthma. This initial inflammation goes away, but eosinophils are causing more and more edema and inflammation in the airway, and this cascade continues. So the mast cells, as soon as the repeat antigen binds to the IgE, which is present on the mast cells, it degranulates, it releases histamines, leukotrienes, and interleukins. Histamines are resulting initially present, which act right away, causes edema, bronchoconstriction, and leukotrienes and interleukins continue and propagate that inflammation. So those who have asthma, they know it. As soon as they get in contact with the inflammation, they feel it, and then the cascade goes on for 6 to 8 hours. The initial part of the cascade is driven by the degranulation of the mast cells and basophils. Latter half of the inflammation is propagated by the Th2 cells. I hope everybody is with me on this, because it's going to get a little bit more complicated right now. We are in 2026, and I want you to understand what is the current thinking of bronchial asthma at this point of time. Please don't lose your mind over that. Let's go over this together. Today, we think asthma itself is 2 different types. It's not just eosinophil all. There is a little distinction between the two. One type of asthma is the typical allergen reaction, which I talked about, in which there is an antigen-antibody reaction, involvement of the basophils, then second exposure and degranulation of the basophils, and degranulation leads to histamines, leukotrienes, interleukins, etc., and later on Th2 cell augmentation. Th2 cell augmentation is this one, initial reaction is this one. So let's look at it. What is the current thinking? There are allergens attached to the airway epithelium. In the cells, there are something called as dendritic cells, DC, dendritic cells. Dendritic cells stimulate the Th2 cells, and Th2 cells release interleukin 4, 5, 13, 14, things like that. Interleukin 5 is the one that specifically attracts the eosinophils into the airways. So there's one type of asthma, which is allergic asthma, which results in accumulation of eosinophils in the airways. It also results in elevation of IgE levels from the basophils. These patients also have atopic dermatitis history and things like that. This kind of asthma is more common in children. When asthma occurs in children, a high number of these kids also give a history of atopic dermatitis, skin reactions. So this is called as Th2 asthma. These patients have high eosinophils in their blood, high eosinophils in their sputum, high IgE level in their blood. There's another kind of asthma, which occurs in adults. That does not require an antigen. It can just be an irritation. Cigarette smoke, gastroesophageal reflux disease, stress. It results in stimulation of another kind of cells called as innate lymphoid cells, ILC2. No need to remember this name. And allergens, inhaled dendritic cells lead to Th2 cells, which is the Th2 cells, which are the eosinophilic attractant cells. They attract eosinophils and cause eosinophilic asthma. Eosinophilic asthma will have high eosinophil in the sputum, in the blood, and high IgE level in the blood. Another kind of asthma is those patients, they don't have specific exposure to allergen, but any irritation, any pollutant, any pollen, anything which irritates the airways, which stimulate a kind of cells in the airway lining called as innate lymphoid cells. Innate lymphoid cells through a different pathway can also stimulate eosinophils, but to a much less level. This type of asthma is called as intrinsic asthma because the precipitating cause is usually a viral infection, stress, reflux disease, obesity, things like that. This kind of asthma occurs in adults. This type of asthma is a little less responsive to inhaled steroids as compared to the Th2 type. So people, what we have learned right now, there are two different pathways for this asthma. When there are two different pathways for this asthma, two different endotypes of asthma. But this results in two different presentations, one in children and other one in adults. The one in children is due to antigen antibodies typically. The one in adults is due to some kind of chronic inflammation leading on to innate lymphoid cells, which though try to stimulate the eosinophils as well, but not to that great an extent. The first type is called as extrinsic allergic asthma or eosinophilic asthma or Th2 phenotype. Second type is called as intrinsic asthma, non-Th2 phenotype or non-eosinophilic types of asthma, though the eosinophilic component is a little less. Sometimes maybe there be an overlap between the two. Let's not get into this. This is not important. The precipitating cause for the intrinsic allergic asthma are stress, reflux, viral infection, obesity, change in the cold weather, etc., etc. Okay, so there are two different types of asthma. People, please be awake. I want you to know this. The treatment may be the same, so slight changes when one with the other. So Th2 asthma and non-Th2 asthma. Today we talk in terms of Th2 asthma and non-Th2 asthma, and I don't want you to look dumb when you go to some pulmonologist's office or allergist's office when they're talking about this and you don't know what the hell they're talking about. So asthma is two types. 15 years ago, we used to call this intrinsic asthma and extrinsic asthma. Today, we call that as Th2 type asthma, non-Th2 type asthma. Okay, so what do these Th2 cells do? They release IL-4 interleukin 4, which is basically helps in producing IgE. It produces interleukin 5, which attracts the eosinophil. Interleukin 13, which when they secrete this molecule, it stimulates the airways to produce mucus production. So Th2 cells lead to IL-4, IL-5, IL-13. No need to remember this, but this makes understanding very well. When IL-4 is elevated, IgE levels are 4. IL-5 is elevated, eosinophils are elevated, and IL-13 is elevated, the patient's having more mucus production. Before I go any further, I want to come down to earth. We learned a little bit more pathophysiology than what we were ready for today. There are distinctions between asthma and COPD, very clear distinction. Asthma, now you understand, is a CD4 lymphocyte Th2 types of inflammation with eosinophils having a big role to play, and it's treated properly, it's completely reversible. COPD is an inflammation of the airways due to noxious stimuli. The cells here are CD8 cells and some macrophage neutrophils. Little role for eosinophils here. It is not completely reversible. Asthma and COPD distinctions should start becoming clear to you by now. Okay, let's keep working on our Th2 and non-Th2 asthma. The Th2 types of asthma occurs in children, IgE level. They have a history of allergies. They have a history of skin rashes, atopic dermatitis, etc., etc. Intrinsic asthma in adults, they have significant airway inflammation, but its eosinophils are not that predominant in that. Neutrophils may be active in that. So you can see the extrinsic allergic asthma or Th2 asthma is very responsive to inhaled steroids. Remember, I keep saying steroids kill eosinophils, and it's very easy to treat extrinsic allergic asthma or Th2 types of asthma. This one, the intrinsic type may respond still to steroids, but its response is not as great. So what are the allergens? What allergens these people have? It can be as subtle as food. nowadays we think food particles, different kind of foods may cause allergies, and that may precipitate eosinophilic inflammation in the body and cause asthma. Very clearly defined are the pollens, the dust, the animal dander. You go to Queens, if the apartment building is not clean, the carpets are not clean, there's high incidence of fungus like aspergillosis, there are more parasites like cockroaches, their droppings, etc. They can all cause asthma. More closer to home, inhaled droppings from the trees, from the plants, from the flowers, the pollens, the grasses, they can cause asthma. Occupational, very big cause of asthma. If you're a painter, if you're a cook, and things like that, that may cause a little bit. May cause asthma as well. Intrinsic asthma is more common in females. It's associated with obesity. It's associated with respiratory infections. In fact, we believe it is also associated with significant stress. Stress sometimes stimulates the airways as well. It may result in cold temperature changes. Many people have asthma just on their response to just change in the cold temperature. You come out from the hot air to the cold area, from cold to the hot area, you start having bronchospasms. So the one thing we do is we take a detailed history in our patient. So a big job for the healthcare provider is to take a detailed history to figure out what is precipitating the asthma in our patients. Going further, since I'm talking to a group of healthcare people here, I do want to let you know that even healthcare professionals are at high risk for certain types of asthma, particularly when we used to use a lot of powder in the glove. That would cause a little bit of skin sensitization and also airway sensitization, and you can have asthma as well. So occupational sensitizers are there, your latex, animal allergen, flour that you use in cooking, woodworkers, welders, a lot of occupations are at risk for occupational asthma. And sometimes you have to take a detailed history as to what is the underlying antigen or sensitizing agent which is causing this problem. So to recap for the nth time, now we have learned asthma we thought was an inflammatory disorder, which is reversible, which is purely eosinophilic. Yes, it is eosinophilic, but it is two types. One, it occurs in children, one it occurs in adults. The one in children has more eosinophils, the one in adults has less eosinophils. The response to the one in younger children to steroids is much better than in adults. And the one in adults may require a little bit more different kind of treatment to completely control it if the patients don't get better. Okay. This is something that I've introduced this concept to you already, but let's take it. How do what are the various phenotypes of asthma? What are the various phenotypes of asthma? I skipped this slide, I think. Every disease today, whether it is diabetes, heart disease, or whatever, sleep apnea for that matter, is looked in terms of two types of explanations. And I want you to get used to these words: phenotype and endotype. If I say phenotype, what that means is disease on its physical examination and history, upon what is the characteristic of the disease on clinical exam that we can see. When I talk endotype, means what is this disease based on the underlying basic pathological mechanism. So in my own way, I've introduced to you, there are two endotypes of asthma: Th2 asthma, non-Th2 asthma. Two endotypes of asthma: Th2 asthma, young children; non-Th2 asthma, adults. These are the two endotypes. So what are the phenotypes of asthma? Before we go that, let's look at the development of the airway. Yesterday we learned When we are born, from child till 15 years of age, 18 years of age, their lungs are growing and our breathing is getting better, then it remains stable going forward. So how does the airway problems occur? The best of the best is patients born healthy and they continue healthy, no problem. This is majority of the population, this top line. This is adulthood. This is when they are born. This is talking about, and the y-axis is the symptom threshold of the based on lung abnormality. You can born, you have a healthy lung, you develop it, you keep going like that, no problem whatsoever. Then there is a group of patient that they born, the lung functions, but around 18, 19, 20, they start having problems with airway disorders, basically Th2 type of asthma. And as I said, some of the kids after 18, 19 years of age, they actually outgrow their asthma and their lung function starts to get better and they're okay. Some may continue to have a problem. Some may continue to have a problem. Then there are people who are healthy initially. They may not have symptoms, but they start having symptoms later year in life, in their adulthood. These are the ones who have basically obesity and things like that. So the asthma phenotypes are different. The two endotypes are Th2 types and non-Th2 type, but phenotypes can be many. We can divide asthma phenotypes into different ones. It can be early onset allergic, means history of allergies, Th2 types. It can be late onset allergic. It can be late onset obesity related. It can be late onset non-obesity related. So we have different kinds of phenotypes of asthma, which I think is beyond the scope of our discussion today. I wanted to introduce the words phenotype and endotype. We have learned today asthma has two predominant endotypes, Th2 endotypes, non-Th2 endotypes. Children, adults, males, females. Steroid responsiveness, not that great steroid responsiveness. Okay. So while we are talking about Th2 endotype, I did say in my first lecture that sometimes children, when they get RSV infection, etc., they wheeze. So all wheezing is not asthma, people. I just want you to know, all wheezing is not asthma. For asthma to occur, there should be a history of wheezing, but there should be a history of reversibility. There is a history of hyperresponsiveness, etc., etc. So when children, parents bring their children to you, and they have had a history of wheezing once or twice before, they want to know whether, doctor, is my child going to develop asthma? That's a very big question in everybody's mind, and rightfully so. So how do we predict asthma development in a child? This is how we do this. If a child after the age of 2 years, if a child after the age of 2 years has more than 4 history wheezing episodes in last 1 year, 4 wheezing episodes in last 1 year, plus either one of these, parent has history of asthma, patient has history of atopic dermatitis, or definite history of severe allergies, one of the three. Parents have asthma, patient has atopic dermatitis history, or has history of severe allergies, you can tell your parents there's a high probability this child will continue to have wheezing and will develop asthma as he grows. Or if patient has 4 episodes and if has 2 of these criteria, peripheral eosinophilia more than 4%, history of food sensitivity, or wheezing not related to an infection. Sometimes infections cause wheezing. You all know that during winter season, we get a little bit of running nose. Some of us are coughing a lot. That's hyperreactivity. Any of the 3 present. Food sensitivity, peripheral eosinophilia more than 4%, or wheezing not related to infection. All of this will predict development of asthma. This is how we predict development of asthma in young children. Okay. I already made the point. How do these patients, asthma patients, present to us? They present with history of shortness of breath, wheezing, and dry cough. How do we confirm it? Chest X-ray is normal. PFTs showed expiratory limitation or obstructive lung defect. Documented airflow limitation, FEV1 by FVC less than 0.70 or lower limit of normal. Or we can show bronchial hyperreactivity. I told you, we do on the PF spirometry, we do first spirometry, we give them bronchodilation. And if on this inhalation of beta agonist, there's an improvement in FEV1 of 10 to 12%, then chances are your patient has bronchial asthma. Lastly, peak expiratory flow. Yesterday we talked about it. Average adults, an average adult, the dimer variation is not that much. Morning and evening peak flow is not that much variation, but in asthma patients, the variation between morning and evening peak flow may be more than 10, 12%. So these are the things that we use to predict or confirm our asthma. In addition, all patients suspected of asthma should have a blood work, and you will measure their eosinophil levels and their IgE levels. Why do we do that? If they are elevated, you have Th2 types of asthma. This will come in the exam. Please know it. We also measure in our patients in the outpatient setting, exhaled nitric oxide. There is a machine in which you basically exhale out like this, and it measures the nitric oxide level in the exhaled breath. Eosinophils lead to increased nitric oxide. So if you have an eosinophilic inflammation in your lungs, your exhaled nitric levels would be very, very high. This test is slowly now available in the outpatient setting. So I don't want you to look confused. If you know, see what people are doing. So we divide asthma as it progresses from mild episodic, mild persistent, moderate persistent, and severe persistent. Needless to say, these patients present with history of wheezing, cough, shortness of breath, and sometimes chest tightness as well. There may be some diurnal presentation. Some patients may have asthma, which is more predominant in the nighttime. Physical examination, you should look for wheezing. You should look for nasal polyps, as in this condition. Yesterday, we learned presence of nasal polyp, history of bronchial asthma, generally predict aspirin sensitivity related asthma. Don't show up without knowing this. Patients who have bilateral nasal polyps and a very severe asthma, generally the culprit is aspirin. These people are sensitive to aspirin, and aspirin sensitivity is causing the asthma. How do we know that our asthma patients, first we confirm it on spirometry. How do we make sure the patient's asthma is controlled? We repeat the PFTs, breathing test to make sure the lung functions have improved. Outpatient control of asthma requires looking at a peak flow meter. Peak flow meter is a device in which patients breathe out every day in the morning to see how much their peak flow is. If it starts to go down, it means their asthma is not under control. We also look sleep absentation from the school, visitations to the ER, requiring more and more medication. These are all subtle things which tell you your patient's asthma is not very well under control. This much we have learned already, so we are past master in this. The way to diagnose bronchial asthma in our patient is by office spirometry. Patients with on this, they will have initially first spirometry, FEV1 is decreased, FVC is decreased, but the ratio is very low, less than 0.70 or lower than lower limit of normal. You give them bronchodilator and you see the FEV1 improves. It improves by at least 10%. You know this patient has bronchial asthma. We learned this yesterday. I'm going to skip this slide, the 4 volumes and things like that. We look at the flow volume loop. Once patient has bronchial asthma, the peak flow decreases. It goes here and becomes more concave. On bronchodilation, this improves back to normal. This is how we predict development of, we predict presence of bronchial asthma. We did this slide yesterday. Spirometry will show in a patient with shortness of breath, history of wheezing, you do a spirometry, evidence of obstruction. You give them bronchodilator if it improves by 10, 12%, and that is what is bronchial asthma. The other types of asthma is patients have history of wheezing, but spirometry is normal. But patient says, I do get his wheezing, doctor. I'm not having it today. To confirm that, you would give them methacholine inhalation. Methacholine causes bronchospasm. So we're creating bronchial asthma in the lab. If the FVC declines by more than 20%, that is presence of asthma. These two pathways should be clear to all of you. Some of these things from my own practice, as you can see, this patient has evidence of slight obstruction, but as we give them bronchodilator, FVC improved from 3.5 to 4.0, FE1 improved from 2.48 to 3.20, 29% improvement. Significant bronchodilation improvement in this patient, presence of asthma. This patient has exercise-induced asthma, okay? This thing. When the patient starts, we measure the FEV1, and as we go along, as time passes, their FE1 starts to decrease. On exercise, it decreases from 100% to 60%. That again is a significant decrease. So exercise challenge can also be used to predict presence of bronchial asthma. Third patient claimed that, no, I have a bronchial asthma, doctor, get me disability. I don't want to go to work anymore. Fine, come to the lab. We give you inhalation of methacholine. We kept on measuring their FEV1s. This is 100%, this is 80%. The patient never dropped more than 9% or so. This patient does not have bronchial asthma. Negative methacholine challenge test has a very high predictive value for telling you that you don't have, it rules out. A negative methacholine challenge test always rules out bronchial asthma. How many times a month I do this, you have no idea. People in this world all trying to claim disability and lifelong money. This is how we pick it up. If you don't have this, you do not have asthma. Other thing is exhaled nitric oxide. It tells you the eosinophilic burden in the lung. High levels tell you more inflammation. And as we treat our patients, they come back after 6 weeks, 8 weeks. We repeat this test. And if the patient is doing better, their levels will go down. So exhaled nitric oxide is one way of monitoring the presence of eosinophilic inflammation. Patients we no longer do this test, but it's important for you to know because patients, those with Th2 asthma and even some with non-Th2 asthma with some eosinophilic inflammation may have high eosinophils in their sputum. What else do they have? C, and C. C is Crayola bodies, which is the sloughed out remnant of columnar ciliated epithelium from the airways. They may have needle-shaped crystals called as Charcot-Leyden crystals, which are the eosinophilic cationic proteins from the eosinophilic membrane, or may have Kirschmann spirals, these lace-like structures, which are mucus plugs from the glands. So there are three things we can see in the sputum of the asthma: C, and C, Crayola bodies, Charcot-Leyden crystals, and Kirschmann's spirals. Peak flow is the way to monitor patient at home. That's the best way to. Peak flow does not diagnose asthma. It helps us monitor asthma in our patients. So patient gets up in the morning at 6 a.m. They blow out into this. It has a little cursor. It tells you what is the level of peak flow. If the needle moves very far, it's green. Middle, it is yellow. Then if it is very close, it is red. Green means you're fine. Yellow means you need to increase your medicine. Red means you need to call your doctor and maybe change your medicines, etc. So asthma can be monitored at home by peak flow meter to be done in the morning. Peak flow meter is very helpful. This is one patient whom I gave peak flow. Okay, we gave peak flow and measure it every day. This is what happened. When it is triangle, patient is at work. When there's dots, patient is at home. When it's triangle, his peak flows are down. When it is this, it is at home, it is good. Work down, at home, good. Work down, at home, good. Work down, at home, good. All right. What happened here? This was a Sunday. He did not go to work, so the levels were high. This is classically what you will see in patient who has occupational asthma. They are okay when they're away from the area of exposure, which is at home. When they're at work, their peak flows are down. So peak flow meter can also help you pick up occupational asthma. We do that all the time. So once you have diagnosed your patient has history of wheezing, history of cough, dry cough, obstructive disease, positive bronchodilator challenge, positive methacholine challenge test. If you did that, how do we treat? What do we want to do? We want our patients' lung functions to improve. We want our patients to be healthy. They want to be able to go back to work and have a good quality of life. All this is possible today. For sake of discussion, I would like to propose that asthma can be divided into mild intermittent, mild persistent, moderate persistent, and severe persistent. None of you will remember this, and I forbid you from trying to mug this. That is not the purpose of this lecture. Idea is to remember mild intermittent patients, how interesting, have symptoms of shortness of breath, cough, wheezing, less than 2 days per week, less than 2 nights per month. Their peak expiratory flow rates, they're more than, FEV1 is more than 80%. The variability of the peak flow from morning to evening is less than 20%. When it becomes mild persistent, means it's there all the time, symptoms more than 2 days per week, more than 2 nights per month. FEV1 may still be preserved, but their peak flow variability is very high. Morning and evening peak flow variability is very high. Then it is moderate and severe persistent. So there are 4 kind of stages of asthma. How do we treat these patients? We want to give patients beta agonists because sympathomimetic agents will cause bronchodilatation. We can also use steroids. We can use anticholinergics, which also cause bronchodilation. We use mast cell stabilizing agents, etc., etc. Something new that you should know is called as biologic therapy. Biologic therapy is the way we target the markers of inflammation in asthma. Remember interleukin 5, interleukin 4, interleukin 13, we can block it. So these are the therapies which are immunotherapies. Basically, these are medicines made to block the end organ. If you've been sleeping, this is what I'm talking about. Remember these IL-4, IL-5, IL-13, we can block these by giving specific medications. Most medications work here on the airways, but here this will go inside the airways and block these so that the asthma cannot propagate. If we can do that, we can have a good outcome in our patients. So, sympathomimetic agents, anticholinergic agents, inhaled steroids, mast cell stabilizers, leukotriene stabilizers, and biologic therapies. Biologic therapies are molecules that block the mediators of inflammation, very specific. They are targeted at IL-4, IL-5, IL-13, and these are becoming more and more easily available and more widely used. That's why I needed to talk to you about the pathophysiology of asthma, because the treatment is based on understanding the Th2, non-Th2, IL-4, IL-5, IL-13, which can be blocked. All right, let's get a little bit more closer to the pharmacotherapy. I want to divide therapy into 2 types, bronchial asthma. One is maintenance therapy or long-term controlling therapy. Many aspects of it. Avoiding allergens is one. Inhaled steroids, long-acting beta agonists, long-acting muscarinic agents, anti-IgE, anti-IL-5, etc., etc. Many of these medicines, the most important long-term controlling agent is inhaled steroids. The most important long-term controlling agent is inhaled steroids because they are the basis of treatment of bronchial asthma. What about the relieving agent? Basically, these are to be used only when I'm having spasm. Remember, bronchial asthma patients can be asymptomatic in between, symptomatic, and then asymptomatic again. So short-term relieving agents are those which relieve the bronchospasm. Two of these medicines I want you to remember. One of them is pure beta-2 agonist, which is short-acting, means albuterol. It has a short-acting agent, or a long-acting beta agonist. The very specific long-acting beta agonist is formoterol. This is the only one approved as a relieving agent. Why? There are many long-acting beta agonists which takes 25 minutes to act, and their action is good for 12 hours. But formoterol, as you take a puff, its action starts within a minute, and it lasts for 12 hours. It's a very interesting medication. So the relieving agents are either albuterol or formoterol. That is it. Relieving agents are either albuterol or formoterol, nothing else in treating bronchial asthma. Rest all are the maintenance or long-term controlling agents. The best controlling agent is inhaled steroid. Mind you, in the a lot of combinations of inhaled steroids, I will go and say inhaled steroid as ICS. If that's okay with everybody, it saves time because I have to repeat it again and again. ICS can be combined with albuterol. ICS can be combined with formoterol. These combinations are also available to patients. Okay, so don't get confused. When I talk about these patients in bronchial asthma, we can give these medicines not as tablets, but many of these are given as inhalers. There are many types of inhalers that are available. Just to recap, the one that is a little round thing, canister, I hope you people have seen it, maybe in your family members or hospital or in the other places that you have shadowed. That's the common way. Patients keep it in their pocket as and when needed. There are some dry powder inhalers as well. These are, instead of giving in a little tube, they're a rounded thing, they take it, it gives a dry powdered inhaler. Then third thing, you can give the same medicine as a nebulizer as well. In this, there's a machine which is pushing air. The patient puts the medicine in a little canister which is attached to it, and then it is given. Nebulizers are preferred. Nebulizers are preferred if patient has severe bronchial asthma exacerbation. Please keep that in your mind. Nebulizers are preferred if patient has severe bronchospasm or exacerbation going on. Otherwise, outpatient, your patient will be on a meter dose inhaler or a dry powder inhaler. Meter dose inhaler or a dry powder inhaler. Why do we use inhalers? Because this way we can give higher concentration of the medicine directly to the lung. It gets absorbed there, so there is no systemic side effect of inhaled steroids, etc. The side effects are much less when we give medicine as inhalers, and it acts much faster. Side effects are less, mode of action is faster and sustained. That is why we prefer inhalers, either meter dose inhaler or dry powder inhaler in the outpatient setting. But for inpatient setting, if patient cannot take a deep breath in, is very short of breath, you do not give inhalers, you give a nebulizer. That's when you give that nebulize. Every patient, you will make a plan, which is called as asthma action plan. Basically, you discuss with the patient the medications, you teach them how to take it. You also teach them how to monitor it by doing the peak flow. And then patient will come back to you for follow-up. You see how things are doing. And if patient is not improving, either patient is not taking the medicine or the way he's taking the inhaler is not proper, you have to teach them, or maybe you need to escalate the therapy. This is the asthma plan. You first write a written plan, you come back, you assess, you adjust. You keep doing it till the time patient is completely absent of shortness of breath, no history of wheezing, and he's able to get on with his life on a day-to-day life. Okay. So let's go through some of the plans as to how we treat. As I said, everybody should get a relieving agent. Everybody should carry a relieving agent. Relieving agent is either albuterol or formoterol and inhaled corticosteroid combination. Formoterol or inhaled corticosteroid combination. This is, everybody should get that. On top of that, patients may require a maintenance therapy. So let's go through this together. Step number one, your patient has very mild symptom. Remember, mild, intermittent, very mild symptoms. What would you do? You give them a meter dose, low dose ICS and formoterol combination. Low dose ICS and formoterol combination. That is the drug of choice for very minimal asthma. You take it as and when needed. Sometimes patients can't get this medicine because it is expensive. It is not covered by the insurance. Then you would give them a short-acting beta agonist, which is albuterol. Short-acting beta agonist, that is albuterol. Step number two. Whenever I say track number one is preferred, then track number two. Okay. Patient still not very happy. He's taking formoterol, ICS as and when needed, is not getting better. You will increase the frequency. You will increase the frequency of ICS formoterol. Or you can give them a standalone inhaled corticosteroids plus SABA as a relieving agent. This is a little bit cumbersome. Track 2 is cumbersome. Please remember track 1 as the treatment. As needed low dose, but with a little bit of increased frequency. Step number 3, I'm still not happy with my control. I will give low dose ICS formoterol, standing orders morning and evening, and relieving in between. This time is not as needed. This is not as needed anymore. He or she is not taking regularly morning and evening and in between this as a relieving agent. So it makes it a little bit easier for the patient. If patient is not able to get this because this is an expensive therapy, you would give the patient any ICS LABA, any other ICS on LABA, and SABA as a relieving agent. Step number 4, still not helpful. I will give a medium dose ICS formoterol combination. Medium dose ICS formoterol as a combination. You can take it as maintenance or reliever, or a low dose ICS formoterol as a relieving agent. If that's not possible, ICS and LABA, and you add a leukotriene antagonist. Leukotriene antagonists are tablets. Step number 5, high dose ICS formoterol maintenance and a low dose ICS formoterol as needed. I've written it as a reliever, but most patients will give high dose ICS formoterol and low dose ICS formoterol as a relieving agent. If that's not possible, you will give the patient high dose ICS, LABA, leukotriene, and LAMA. This is what we used to do 4 or 5 years ago, but still possible. ICS, LABA plus leukotriene antagonist plus LAMA as maintenance therapy and SABA as a relieving agent. It gets confusing. Lastly, if still not happy, I will go to the biologic therapies. We add biologic therapies. Something you have realized cleverly, the GINA, which is the Global Initiative for Asthma Control, teaches you that right away from day 1, now we want to give inhaled steroids along with short-acting beta with formoterol as the basis of the treatment. Every time I said it was ICS, ICS, ICS. So the basis of maintenance of asthma is inhaled steroids. We adding formoterol to it. And if not helpful this, then we would use the biologic therapies there, which can be anti-IgE, anti-IL-5, anti-IL-4, and some other ones as well. Please, I do not want you to remember these names. This is to complete the picture of the pharmacotherapy of asthma, that beyond inhaled steroids, long-acting beta agonist, leukotriene antagonist, and long-acting muscarinic agents, we have a biologic therapy also available to the patient. This is the summary slide, which is important for you to know. Same thing in a more clearer pattern. Stage 1, patient with symptoms occurring less than twice a month. As needed, low dose ICS formoterol. Step 2, patient with symptoms occurring more than twice a month. Mild intermittent, become mild persistent. Low dose ICS as needed SABA or as needed low-dose ICS formoterol. This is what we prefer. Step number 3, patients who have symptoms present most days, who are waking up due to asthma at least once a week. Daily low-dose ICS formoterol, both as a relieving and maintenance treatment, or if this is not possible, daily low-dose ICS and long-acting beta agonist and short-acting beta agonist as a relieving agent. Step 4, patients with persistent asthma, daily medium ICS formoterol as this agent. If not possible, daily medium dose ICS LABA plus leukotriene antagonist as needed SABA. Step 5, for patient whose asthma remains uncontrolled despite adherence to step 4, you will refer for phenotypic assessment for biologic therapies. Then you can add even LAMA to these patients. You can add biologic therapies to these agents and go from there. So for asthma, right from very beginning, inhaled steroids have a role. Let me just understand this. We use formoterol as a relieving agent as well as maintenance agent as we see, and we go from there. If ICS formoterol combination is a bit expensive and not all patients may be able to get it from their insurance, in those cases, we use the other option of ICS, any inhaled ICS and SABA here, ICS and a LABA and relieving agent SABA, ICS LABA leukotriene antagonist and SABA, and high dose ICS LABA leukotrienes and this combination therapy. So this is the roadmap for treating bronchial asthma. And for stage 5, and those who are still not happy, we have many other medications available. These are the biologics approved. I would not go around remembering these these names. As long as you remember that biologic therapies specifically targets the markers of inflammation which propagate the inflammation, IL-4, IL-5, IL-13, there are many of these available. This is not going to leave you. When the allergists come and ENT people come, they teach you about nasal polyps. They will say if it's allergic nasal polyp, we also use biologic therapies. Dermatologists will come and talk about skin reaction. They will say, oh, we use the same kind of eosinophilic inflammation in the skin. We use the same kind of biologic therapies. So please, people, wake up. A lot of biologic therapies have come in and this is only increasing. And every 2 years, I have to change the slide because the number keeps on increasing. You can see how many I've added here. The last one which was approved, I didn't even add here because I think at your level, it is not important to know the name as much as to know that inhaled steroids, formoterol, leukotriene antagonist, anticholinergics, if all this is exhausted, your patients will go on biologic therapy. In any big practice, up to in pulmonologist practice, 5% of patients with bronchial asthma will be on this. I don't expect to see this in primary care practice, no. But patients who have severe uncontrolled asthma generally nowadays are on biologic therapies. And it is fair game to ask what is biologic in the exam. I don't want you to look left and right and say nobody ever told me and nobody ever taught me that way. I've taken you these step 1, 2, 3, and 4. Everybody will get a relieving agent, which is ICS and formoterol of some kind, and then you increasing the dose of inhaled steroids, and then add LAMA, then add long-acting muscarinic agent and leukotriene antagonist to this treatment. This is the preferred treatment. The alternative treatment is to give them just albuterol and keep going on inhaled corticosteroids. Today, we follow the top line, track 1 as the treatment. There is a science behind which kind of biologic therapy needs to be used. That I would leave it to the specialist. Those who have a lot of allergies, we use an anti-Ig agent. Those who have predominantly very high eosinophil count, we'll use IL-5, Dupixent. Those who have allergies and eosinophilia, we may use IL-4, thing possible. Those who have type non-Th2 type of asthma and very severe, we use something called as tezepelumab. This is, and even if there is no eosinophilia, no Ig, severe asthma, this is the drug of choice. Some other treatments are also done in our patients, but Tezlimumab is the biologic. If you don't have eosinophilia and you still have very severe asthma, which is not getting controlled, that's what we would use. Not to forget, the treatment requires you inquiring and trying to control, inquiring and trying to control patients' allergens as well. And that requires maybe sometimes sending the health department to the house or looking at advising patients that their exposure to dust, mites, chemicals, things like that at home, no, there should be no carpets in the apartment if patients having allergies. If their patient has pollens are the culprit, then maybe you wear a mask when you go into the garden and things like that. No smoking, no passive smoking, no leaky basements and no dampness in the house. All these things should be looked into. Please, allergen avoidance is also very important in management of bronchial asthma. Asthma exacerbation. Now, I told you about many times these patients will come back very shortness of breath. What is exacerbation? When the symptoms are much more pronounced. Sputum shortness of breath and their cough is much more pronounced. Their wheezing is much more pronounced. And patient says, the kind of regimen that you have given to me is no longer acting. When the patient has very severe shortness of breath and they are very tachypnic, they need to come to the emergency room. What are the other signs of very severe asthma? They may have low oxygen, hypoxemia may be there. They will be using their accessory muscles. Their heart rate will be high. Respiratory rate is more than 25, 30. The peak flows are decreased. Pulse oximetry is less. That is one time. If patient is presents to the ER with asthma exacerbation, don't come to the exam without knowing that you would do a chest X-ray first. Because asthma patients are at risk for pneumothorax. If pneumothorax is present, patients will be very short of breath, etc. But that time, bronchodilators are not going to do anything. So every patient with severe bronchial asthma exacerbation should be screened by taking a chest X-ray to rule out a pneumothorax. So let's review how do we treat when it is in the very severe bronchial asthma. You assess patients using accessory muscles, tachypnea, tachycardia. They may have pulsus paradoxus. Their peak flows will be decreased. Pulse oxygenation, pulse oximetry is decreased. Late stages, hypercapnia, CO2 may start to go up. Blood work should get CBC and look for glucose and basic workup as hemoglobin should be measured. What is pulsus paradoxus? It's abnormally large decrease in systolic breath pressure on deep inhalation. When you take a deep inhalation, your lungs expand and it also compresses the IVC, which is coming out from the T10 region of the diaphragm. It compresses that so that blood venous return is decreased. Normally, on a deep inhalation, the systolic blood pressure decrease is less than 10 millimeters of mercury in all of us. But in patients with bronchial asthma, very severe bronchial asthma, they may have pulsus paradoxus that when they take a deep breath in, their blood pressure drops by more than 10 millimeters of mercury. That's a sign of severe bronchial asthma. Just to know that pulsus paradoxus can be from many causes, from cardiac tamponade, massive pericardial effusion, constrictive pericarditis, pulmonary embolism, tension pneumothorax. So pulsus paradoxus is a very sinister finding. It can occur in many causes. On deep inhalation, drop of the systolic blood pressure by more than 10 millimeters of mercury is pulsus paradoxus, and a person who has history of wheezing, shortness of breath, presence of pulsus paradoxus means their bronchial asthma is out of control. These patients may have what is called as Kussmaul sign, which is the inspiratory rise of the JVD. Every time you take a deep inhalation, the JVD rises. Because deep inhalation, the venous return is decreased, the JVD rises. That can be seen in bronchial asthma as well. So in bronchial asthma, if you look at patients' ABGs, I kind of gave you a hint of that in my first lecture. Initially, in mild disease, The PaCO2 is decreased, PaO2 may be normal. As disease worsens, pH is still normal, PaO2 is decreased, PCSCO2 now becomes normal because it starts to rise. Severe bronchial asthma, pH is decreased, PaO2 is decreased less than 60, PaCO2 is increased more than 45 millimeters of mercury. That's a very severe bronchial asthma. Elevated PaCO2, I can shout at the top of my voice, and some of you are still sleeping and they need to wake up. Elevated PaCO2 in patients with bronchial asthma means very severe bronchial asthma, near death. These patients should be admitted to the ICU. A patient who cannot maintain one full sentence while taking a history. A patient whose peak expiratory flow rate is less than 50, respiratory rate more than 25, tachycardia more than 110. These are all subtle signs that patient's bronchial asthma is not under control. How do we treat these patients? Patients should be given bronchial beta agonist therapy, and you continue it. You start with SABA. You also give the patient oral prednisone. That's the only time you give oral steroids in bronchial asthma, because patients so short of breath, they cannot take an inhaled thing. We give them nebulizer, albuterol or SABA as a nebulizer, oral prednisone, give them oxygen, and do a chest X-ray. And if there's a pneumonia, give them antibiotic. You keep giving beta agonist therapy through the nebulizer till the time the patient bronchospasm starts to get better. One more time, in severe bronchial asthma, in the emergency room, this time we don't give a meter dose inhaler, we give a nebulizer, and you keep giving the doses of nebulizer every 10-15 minutes till the patient's bronchial asthma starts to get improved. In addition, we give them oral prednisone. Oral prednisone again will get absorbed and decrease the inflammation. You give them oxygen and you give them antibiotics if their chest X-rays show any evidence of pneumonia. Once patient's bronchial asthma gets better, his peak flow starts to improve, he feels okay, patient can be discharged home with a tapering dose of prednisone. Nebulizer is converted back to an MDI, and an inhaled steroids again is emphasized, and patients then follows up with his primary care physician. At the time of discharge, you will make sure your patient has a relieving medicine, either a SABA or ICS formoterol combination. Patient has oral steroids for 5 to 10 days, slowly decreasing. And as soon as it decreases, this oral corticosteroid therapy stops, patient will start the maintenance inhaled corticosteroid plus formoterol or any combination therapy that patient is on. All patients who are discharged from the hospital should be reevaluated within 24 hours in your primary care's office so that we can up titrate or down titrate the treatment. If patient has an infection, antibiotics should be continued. Patient should get an allergy evaluation if they have very high allergy level, they have skin sensitivity, they have nasal polyps. Please have them seen by an allergist as well. Most important thing in bronchial asthma discharge is to make sure patient knows how to take the inhaler. One of the more common causes of patients getting admitted repeatedly is patients who do not know how to do the MDI, the hand-to-mouth coordination. If it is not good, the medicine, they press the canister, it only goes in their mouth. It's not going in their lungs, then their asthma is not getting controlled. So non-compliance and not knowing how to take the inhaler is a very important factor in patients not improving. Don't just keep increasing the medicines. See how we can improve their compliance to these medications. I talked about oral steroids. Please do not keep prescribing oral steroids in bronchial asthma patients. Definitely patient will feel better, but there are side effects. That's why we do not recommend oral steroids as continuous oral steroids as treatment in bronchial asthma. If we do that, patient will get moon phases, they get adrenal suppression, they will have obesity, they'll have psychosis, they have osteoporosis, they have gastritis. And now we also know long-term steroid use propagates non-alcoholic fatty liver disease. So all these are side effects: osteoporosis, depression, reflux, increased blood glucose, worsening diabetes, and Cushing's disease kind of features are all side effects of corticosteroids. I had briefly mentioned leukotriene antagonists. Leukotriene antagonists can be used in our patients if the ICS-LABA combination is not working. These are oral tablets to be used in patients as an adjunct therapy, not as the first line of treatment. Patients who are at risk for death, who are at risk for that? Patient who has required multiple intubations in the past is at risk for death from bronchial asthma. Patient who has had repeated ER visits is at risk for problems. Patient who's non-compliant to inhale corticosteroids is at risk for death. Patient who's using too much albuterol, it means they are not using their inhaled steroids properly and they're using too much ICS, they are at risk for problems. Patients who have severe food allergies leading to very eosinophilic inflammation in the gut and the lung, their asthmas are not easy to control. They are also at risk for asthma-related comorbidities, including death. Please keep that in your mind. I had mentioned this yesterday a little bit. What other medicines can lead to poor control of asthma? One is non-steroidal anti-inflammatory drugs. Patients who are on the beta blockers, patients who are on cholinesterase inhibitors for myasthenia gravis kind of things. Sometimes, other medications like carbamazepine, etc., can cause bronchospasm. I also want you to know any kind of injection that you get which has protein in it, whether it is vaccine and things like that, sometimes that can precipitate a bronchial asthma reaction. Something that you should know, that anytime you get a protein injected in your body, vaccine is nothing but kind of a protein. The carrier in the molecule in that is a protein that can also cause bronchospasm. All these should be asked, addressed to, and advised appropriately in patients if they have bronchial asthma associated with this. I've taken you through a big journey of bronchial asthma and divided the lecture into 4 parts. What were they? We learned asthma as COPD and asthma and bronchiectasis as 3 diseases, but part of the airway spectrum. We learned today asthma is an eosinophilic inflammation. It is an airway disorders. If treated properly, it is reversible. It is also associated with excessive sputum production and bronchial hyperresponsiveness. It's more common in children than in adults. Then we learned that the allergens can be outside, that we inhale, or can be inside, can be stress, can be infection, can be obesity, can be reflux, can be cold temperature, etc., etc. We have learned the role of IgE, and the role of mast cells, which initially propagate the bronchial asthma reaction, but it continues on its own because this is not the only thing that occurs in bronchial asthma. 2 things are occurring. Allergens go in, mast cells regranulation, activation of Th2, and recruitment of eosinophils and propagation of that. Eosinophils are the ones which are causing bigger damage in our patients, so that needs to be controlled, and inhaled steroids kill it. Then we learned the 2 Th2 and non-Th2 types of asthma. Th2 types are more responsive to inhaled steroids. This one is a little less. This is more common in children. This is less in adults. We talked about differences between asthma and COPD. We'll look at that again. Extrinsic asthma, which is Th2 types in children, high IgE level, high eosinophil levels. Non-extrinsic or intrinsic asthma or non-Th2 asthma in adults related to stress, infections, etc. The allergens can be wide. We learned today from food to grass to pollen to occupation to medicines, and that needs to be taken into the history. We also learned today now that we can divide asthma into two endotypes, Th2 endotypes, non-Th2 endotypes. We also learned we can look at endotypes, essentially means tell the disease process in which we know the underlying pathway of mechanism. We can also divide into phenotypes. Phenotypes essentially tell you the disease process, how it is occurring clinically. So there are two endotypes of asthma and two endotypes of asthma, Th2 endotype and non-Th2 endotypes. But phenotypes can be many. It can be early onset allergic, late onset allergic. It can be late onset obesity related, late onset non-allergic related. Many different kinds of phenotypes are present. Phenotypes is how the patient clinically present. Endotype is when we know what is the underlying pathological pathway causing the disease. Understanding endotypes helps us tailor-made the therapies much better. We learned the predictive method to predict development of asthma in children. I will ask this in the exam. We also learned that diagnosing asthma requires history of wheezing, evidence of obstruction on PFTs, evidence of bronchodilation on spirometry or a methacholine challenge test positive, and the peak expiratory flow rate is variable from morning to evening in bronchial asthma patients. On the blood test, if Th2 type patients will definitely have high eosinophil and high IgE. Some patients may also have inhaled nitric oxide. We looked at how we're going to follow our patients, spirometry. We are past masters in that. We looked at the role of nitric oxide as to helpful in following up with patient. If patient getting better, exhaled nitric oxide is going down. Exhaled nitric oxide reflects the inflammation in the lung. Sputum findings come in the exam once in a while as C, CNC, Crayola body, Charcot-Leyden crystal, and Kirschmann spirals. The best way to follow asthma is doing peak flow. Peak flow meter should be done at 6 a.m. in the morning. Goals for asthma therapy is to control asthma well. We divide asthma into mild, intermittent, mild, persistent, and moderate and severe. Treatments are based on controlling medicines, maintenance, and relieving. Relieving medicines are two, SABA or formoterol and ICS combination. Today, we use the first line of short relieving agent is formoterol along with ICS is the best relieving agent. It can also be used as a maintenance therapy. Most of the inhalers are either metered dose or dry powder, nebulizers only to be used when patient is very, very sick. And I took you through a pathway. Initially, low dose ICS formoterol, then as needed ICS and formoterol, then low dose ICS formoterol mention and releasing therapy, and if need be, you'll add something more. Fourth, medium dose ICS formoterol maintenance therapy, and if you need to, you can add LABA and LAMA to it. And lastly, in patients who are very well not controlled, you can use high dose ICS, LABA, leukotriene antagonists, LAMAs, and biologic therapies. Please know this well. Many types of biologic therapies available. They help pathway, the lower pathway. They help target the markers of inflammation, IL-4, IL-5, and IL-13. No need to remember the names of these medications. How we use these biologic therapies is based on some science, not necessary for you to know, or I will not ask specific details in the exam as long as you know what is biologic. Environmental control is very important in bronchial asthma. In bronchial asthma, we always do, if you have exacerbation, we always rule out a chest X-ray to rule out pneumothorax, pulsus paradoxus, Kussmaul's sign, rising ABG are all signs of worsening bronchial asthma. Treatment is give them bronchodilators. Which one? Nebulizers. This time we give them SABA, albuterol as a nebulizer because formoterol and ICS as a nebulizer is not available. So use a short-acting beta agonist given as a nebulizer. You give them oral steroids. You give them oxygen. If there is hypercapnia, then we'll put them in non-invasive ventilation. And if there's infection, you give them antibiotics. So when the patient comes to the ER, you continue the short-acting beta agonist through the nebulizer every 10 minutes or so till the time the bronchospasm gets better. Give the patient prednisone, feed the patient oxygen. Keep monitoring. And if the patient gets better, patient can be discharged on tapering dose of prednisone and a relieving agent and a maintenance therapy, and to be followed up in the doctor's office. This is the orders. I must have either a SABA or ICS formoterol, a short course of oral steroids, and then must start a maintenance therapy of ICS inhaled corticosteroids along with a LABA. Once this therapy finishes, patients should be evaluated within 24 hours after their discharge. If there's an infection, give them antibiotics. If patient has very high Ig level or high eosinophil levels, they also, or nasal polyps, they should be seen by an allergist as well. Please educate patient about correct way of taking the maintenance therapy, the inhalers. Steroid side effects we talked about, which will come in the exam. Leukotriene antagonists are adjunctive therapy to be used if inhaled steroids and bronchodilators are not working. You can add a leukotriene antagonist to the treatment as well. Risk of death, non-compliance, repeat admissions, or getting intubated. Please don't forget severe food allergies which are not addressed can cause persistent, very severe bronchial asthma. Lastly, also look at patients' medicines. Some of them may be interfering, particularly carbamazepine, which is an anti-seizure medication, non-steroidals, beta blocker, etc., may be causing problems to our patients as well. I hope we are a champion on bronchial asthma now and we understand its nuances. Any questions at this point of time? Everybody knows tomorrow's lecture is 4 o'clock is on the Zoom, right? Everybody knows, yes? Everybody say yes. Tomorrow's lecture is at Zoom and it starts at 4 o'clock and we'll continue with COPD at that time, okay? If no questions, have a good night. Thank you.